In this talk, I will show you how Bausch and Lomb technology allows to manage all the steps in complex cases of VR surgery. These are my financial disclosure. I will review the main surgical steps and the main function and features of the machine. Let's start with trocars that can be easily inserted simultaneously. This allows for a symmetric stabilization of both hands with no need for forceps or plugs. A synergetic chandelier can be inserted for endoillumination, which is very useful in bimanual surgery. With trocars, you can manage even complex cases like this child with cornea decompensation and retinal detachment. This is the retina of the same patient who suffered from Peters anomaly and retinal detachment with the PVR. The trocars are very sharp and can be used even to create a posterior sclerotomy and drain the subretinal fluid in a case of persistent retinal detachment with no visible breaks. It can be used also to remove subretinal strands. This is the view through the intraoperative OCT showing the detachment, the tip of the trocar, the reabsorption of the fluid when the trocar is retracted. What I like the most in vitrectomy is the double linear mode allowed by the foot pedal. With this feature, I can control both in a linear fashion the aspiration and the cut rate and adjust according to the surgical step. This is an example of well-visible core vitrectomy of a dense vitreous hemorrhage. I am using a low cut rate, lower, let's say 5,000, and high vacuum 400 millimeters of mercury. The peripheral vitrectomy can be performed with different parameters, 7,500 cut rate and lower vacuum, 200 millimeters of mercury. And even more, the shaving part allows to remove the last remnants of vitreous with a very high cut rate, 7,500. Let's remember that with the B blade, it is in fact 15,000, and the lower vacuum rate, 150 millimeters of mercury. This is a case of inferior relapse of retinal detachment. In this case, the vitractor can be used to remove the cortex as if it was a forceps. I found vitreous cortex staining with triamcinolone, and then I'm working it by manual technique to remove the cortex with the scraper and aspirating the cortex at low vacuum with the vitrectomy probe. The retina can be detached by injecting subretinal BSS through a 41 gauge needle connected to active injection in the same way as we inject silicone oil. You see the terminal side of the 41 gauge needle. This is a case of subretinal hemorrhage in a one-eyed patient. I am about to perform a choroidal transplant after removing clots and the CNV. So you see here the detachment, the active detachment of the retina by injection of subretinal BSS. A retinotomy can be performed with the probe by setting the parameters to let it work as a scissor with the advantage of simultaneous aspiration. This is an example of peripheral retinotomy performed at high cut rate and low vacuum. It's like a scissor. And this is an inferior retinal detachment relapsed after prior vitrectomy and 360 buccal. At the end of the oil exchange, I observe a residual detachment and traction close to an inferior break. There are no membranes to peel, therefore I decide to proceed with a retinotomy. And this is the retinotomy performed under silicone oil, very efficiently, like if it was in fluid. And this is the result of the retinotomy showing the retinal retraction after the cut. So what if a patient comes for second opinion and had already 5 surgeries for retinal detachment? It seems okay at first, but then we discover with wide field OCT that he has a retinal detachment under silicone oil. And the intraoperative OCT detects a fine, immature PVR that needs to be peeled first. I also proceed after peeling with a retinotomy. Unfortunately, the previous retinotomy was very posterior and every revision it becomes more posterior. We should always remember to cut as anterior as possible and only when there are no more membranes to peel. The intraoperative OCT allows to have confirmation of complete release of traction. Switching to endotiathermy, we see that it can be used to design, cauterize, and cut an area of choroid which is going to be transplanted under the fovea. Basically, you can cut and cauterize at the same time. Let's switch to fluid exchange. The fluid-air exchange through the vitrectory is particularly fast and can be easily repeated multiple times with different purposes: to allow better retina staining, to remove oil, to complete retinal detachment, or just to allow air to enter at the end of a case. The procedure of injecting oil through air is very similar whether you inject light or heavy silicone oil. So you basically have an eye filled with air. You allow oil to enter the eye through a metallic cannula connected to an oil-filled syringe. The oil fills, let's say, 80% of the eye, and then air is stopped. You will see the last bubble of air, and the air will exit the eye, and you can complete the filling of silicone oil. But if you want to inject oil through PFCL, then I use the double linear mode. In this way, I can control the injection of oil by pushing down the pedal and the aspiration of PFCL by pushing to the right the pedal, but you can set the pedal and the parameters as you like. So before starting the injection of oil, it is very important to fill the cannula with oil in order to avoid strong and abrupt injection of oil through a peripheral retinotomy. And it is also important to remove the residual BSS with the vitrectomy probe, which is always behind the lens. And then you can complete the oil by exchanging PFCL aspirated around 150 millimeters of mercury and injecting silicone oil, but you can't change the parameters based on the intraocular pressure. The exchange of PFCL with heavy silicone oil follows the same protocol. The main difference is that it is difficult to recognize the surface between the two substances. So I suggest once a while to wait a few seconds, stopping the injection and waiting for the PFCL bubble to reform for the surface tension. At the end of this video, you will see that the interface is much better visible. Because the PFCL tension allows the bubble of PFCL to reform. So just stop once a while injecting and wait to see the interface. I advise to aspirate the last drop of PFCL with a backflash cannula with the aspiration hole at the end of the cannula facing the PFCL bubble in order to remain further away from the macula. So what about silicone oil aspiration? The aspiration of light silicone oil is easy to perform through this large tube that can be connected to the trocar once the external valve has been removed. We should pay attention to the IOP because you likely have silicone oil in the infusion cannula, so BSS will come with a delay and you could have hypotony. So wait for the BSS to come before aspirating heavily. And then when BSS enters, you can complete the aspiration very quickly. If you aspirate heavy silicone oil, do not use the large aspirating cannula. Use the metallic tube to be inserted into the 23G cannula and push the cannula mildly toward the posterior pole. At the same time, you can use the light pipe to push the heavy oil bubble toward the aspirating cannula, and this maneuver prevents the bubble of oil to sink at the posterior pole. So in this way, you can complete the aspiration of heavy silicone oil without using long cannulas, which will take much more time. In summary, the machine is complete, versatile, and safe, and you can perform any type of surgery. Thank you.